Hello, everyone. I'm Bob Ponec. I'm a GI specialist here at Salem Gastroenterology Consultants and Salem Hospital. And I'm going to be talking to you today about colon cancer screening 2021, early detection and prevention. And my goals are to update everyone on colon cancer screening. We'll talk about the new guidelines, including a new starting age for screening, starting above age 45 in average risk individuals. Also, the goals of screening for colon cancer, both early detection and prevention, and the types of screening, how they compare, and which two are the top choices of screening tests and why. So why are we talking about this now? The pandemic delayed and prevented screening tests, not only for colon cancer, but for many cancers, and we desperately need to catch up. Routine cancer screening plummeted during the COVID pandemic, and the National Cancer Institute estimates that there are going to be tens of thousands of excess deaths due to canceled or delayed cancer screening, not just in colon, but for others like breast, etc. Now it is safe to come in for screening, including endoscopy, and we can talk about this in the question and answer session, but there are multiple precautions that are being taken, multiple protocols, so it's probably safer now to come in for an endoscopy than to go to the grocery store with all of the precautions we take. There are new informations and guidelines for 2021, including how to do this and when to do this. So the question you may be asking yourself is, how worried should I be about this? And I'm abbreviating colorectal cancer as CRC in some of these slides. Well, colon cancer is the third most common cancer in men and women in the U.S., and it ranks only second to lung cancer as a cause of cancer death in the U.S. And in 2020, just this last year, nearly 150,000 people developed colorectal cancer and 53,000 plus died from it. And this is from a largely preventable cancer. And the problem is about a third of Americans are not up to date on their screening. Now here's a diagram of the colon and also an x-ray picture of it showing that there are different regions of the colon. The lowest part of the colon down at the bottom is called the rectum, and the other areas of the colon are named going all the way around to the other side called the cecum. Now here's a picture from a colonoscopy looking at the inside of the colon, and the red arrow points at a typical polyp, and this one is an adenomatous type polyp, one of the precancerous types of polyps. And this is one of the other main precancerous types of polyps called a sessile serrated polyp. I say, where's Waldo? Because these in particular can be very hard to see, and you have to know what you're looking for. Either of those can turn into this over time. This is a large circumferential colon cancer, so this is the enemy. So first, some definitions, because I think it's very important, and I see a lot of confusion not only among patients but among physicians out in the community about what we mean when we say screening, surveillance, or evaluation. Screening is when a patient comes in and says, I just want to try to prevent colon cancer. I don't have symptoms. I don't have any prior history of anything, polyps, cancer, anything. I haven't had any abnormal tests. Now, it's average risk screening if they don't have high-risk family history or something that puts them at higher risk. It's high-risk screening if they do have a family history. So basically, only average risk screening are the types of patients. Now, this is a large proportion of the patients, but those are the only types of patients for which one of several methods are recommended for colon cancer screening. Everything below that, colonoscopy is the only recommended test. So for instance, high-risk screening or for surveillance. Now surveillance is if somebody has had polyps before or cancer before in the colon, or if they have inflammatory bowel disease, it puts them at risk for colon cancer. Or evaluation, if one of the prior screening tests, like checking for blood in the stool or something called Cologuard or CT colonography, are positive, then you get a colonoscopy. Or if the patient has a problem, iron deficiency anemia, or symptoms like diarrhea, change in bowel habits, blood in the stool. So where do we get the information from that we're going to be using to give these recommendations? There are a number of places. The United States Multi-Society Task Force, which is a combination of 3 of the main gastroenterology organizations in the U.S., has its own series of recommendations about cancer screening. The American College of Gastroenterology, one of these 3 organizations, came out with new 2021 guidelines, very timely for this talk. It was just a few months old. They're hot off the presses. The main one, though, that really has changed things is the thing on the third there, the USPSTF, the United States Preventative Services Task Force. They came out with 2021 guidelines. This is a national organization of experts from all around the country, not just gastroenterologists, but statisticians, nurses, pharmacists, physicians, experts in public health. And they look at the data and come up with recommendations about who gets screened, when they get screened, and with what. They use information that they actually asked to be collated by the next thing down on the list called CISNET, Cancer Intervention and Surveillance Modeling Network. Again, multiple organizations around the country at universities that look at colon cancer, look at the screening tests, what their strengths and weaknesses are, and make recommendations. So this is just for your reference, in case anybody wants to look it up later. The American Journal of Gastroenterology published the ACG guidelines this year, and JAMA published the U.S. Preventative Services Task Force guidelines this year. So again, just to reiterate, average risk is they don't have any of these other things: symptoms, abnormal tests, high-risk family history, ulcerative colitis or Crohn's disease, or prior polyps or cancer. So going back to the beginning, how does colorectal cancer start, and how is this possibly preventable? Well, it starts slowly, silently, over the years from a polyp in the colon. And about 70% develop out of the first picture I showed you, the adenomatous polyp, and about 30% from those subtle sessile serrated polyps. So you need to, A, hopefully find colon cancer early if you have a screening program, but B, most importantly, try to prevent it by catching and removing those polyps. Now, where do the polyps form in the colon, and where does a cancer form in the colon? This is a diagram of the colon with labels for the various parts, and it is scattered throughout the colon. One of the rather unusual things that's been noticed is that in patients who are older that get colon cancer, they tend to have it on their right side. In patients that are younger that get colon cancer, they tend to have it in the rectum or on their left side, in the lower part. No one really has a great explanation for that, but it's just one of those things that makes us realize we need to be able to check the whole colon, because it could be anywhere. So who's at risk? You may ask yourself, am I really at risk for this? Do I really need to worry about it? I think I hear from a lot of female patients, they say, well, this is a man's disease, isn't it? No, we are all at risk as we age. There's up to a 6% lifetime risk. So about 1 out of 16 to 1 out of 17 people are going to get colon cancer if you don't do anything to prevent it. About 85% of them do happen in people over the age of 50, so we know who we should be targeting. The average age of diagnosing it is in their upper 60s, but there's been a very disturbing recent increase in colon and especially rectal cancer in younger people. And now a third of rectal cancers occur in people below age 55, some as young as in their 20s. What if I don't have a family history? Sorry, you're not off the hook. About 3/4 of new cases don't have a family history. If you do have a family history, your risk is up significantly, like they show here. So put it another way, if you had 100 people, if this pie graph was 100 people that came through the door who had a colon cancer, and you asked them, do you have any family history? 75 of them would say no, no family history, so they're sporadic. About 20 of them would say, yeah, I have a family history. I have a brother, a father, mother that had colon cancer. There are a couple smaller slices of the pie near the top there, FAP and HNPCC. Those are genetic syndromes. Now, they're a smaller slice of the pie, but they're important because people that have that genetic syndrome are at very high risk for colon cancer and others. And then IBD for inflammatory bowel disease like ulcerative colitis or Crohn's. So how much difference does it make? Take myself, for instance. My mom had developed colon cancer around age 60. And she didn't get screening, by the way. She blew it off, even though, of all things, I'm a gastroenterologist. So she didn't listen to me, and she got colon cancer. And so that means I had a first-degree relative that around age 60 or less got colon cancer. So my lifetime risk just tripled. Thanks, Mom. So FDR on this diagram, or on this chart, says first-degree relatives. SDR, second-degree relatives, like a grandparent, for instance, or third-degree relatives further away. So family history does make a difference. And patients who have a family history should really only get colonoscopy for screening, should get it started younger and get it more often, as I have. Other risks besides aging and family history. Yes, the American diet, low fiber, high fat, smoking, excess alcohol, obesity, diabetes, certain medications, maybe changes in gut flora directed by diet. A lot of us have asked this because, especially in the younger people who are getting more colon cancer and more rectal cancer, why is that? It may have something to do with these things. Well, currently in the U.S., only about 60% of people who should be getting screened are getting screened. Now, more than half are getting colonoscopies, but many people just don't think it applies to them for various reasons. Maybe it was never recommended by their doctor, or they just don't want to. But it's very important. And starting with the one thing I said, catching colon cancer early makes a huge difference. Now, on the up and down part of this graph, that's survival probability. So the top would be 100%, where it says 1. Going across from 1 to 12, that's years from detection. And you can see there's these different curves. There's one that goes straight across near the top. Well, that's the good curve, meaning your chance of surviving over 10, 12 years. Now that's high because that's the group of people where the colon cancer was diagnosed early, stage 1. The one that drops very sharply so that it's almost down to 0 by year 5, that's people who were diagnosed at stage 4, so where it's metastatic by the time they were found. So then the question is, how would I know if I've got colon cancer? That's another thing we hear all the time. Well, I don't have any symptoms, so I must not have it. Early on, neither polyps nor colon cancer really cause any symptoms, so you can't tell by the way you feel. Later on, if you wait until there are symptoms, and if those symptoms are from colon cancer, like abdominal pain, bleeding, anemia, odds are pretty good that it's already spread and you're going to be on that bad curve. So what about screening? It's been around for a while. Is it helping? The data is very strong for that it is decreasing the incidence, meaning every year how many new onset cases there are, and the death rates. It's dropping by a few percent per year, and that's felt to be mainly due to screening, meaning that it's either prevented by removing polyps or it's caught earlier. But of course, even if a person develops colon cancer, much better cancer care over the last 20, 30 years have improved survival too. So it's not just the screening. So getting back to this thing that I said was a game changer, the United States Preventative Services Task Force, they looked at all the data, came out with this year with their recommendations. They now recommend that starting at age 45, everyone, and we're not talking about high-risk people, but average-risk people get screened. And that goes at least until 75. What about between 76 and 85? They still actually recommend screening. But in that group, they call it a grade C recommendation, meaning that the magnitude of the benefit for someone who's, say, 75, 80 or so is less, and perhaps the risks of the screening are somewhat more because of other medical problems. So that is a group that needs to be individualized. Again, we're talking about average risk screening. We're not talking about people with symptoms or people with prior polyps or cancer. So again, when to start? Starting at age 45 for everyone, except for if you have a family history, in which case you may start at age 40 or even younger, like some of the things listed here. People with these genetic cancer syndromes would start in their 20s, for instance, or even in their teens, or after about 8 years of ulcerative colitis or Crohn's disease. So the data to support the idea that you should start for average risk people at age 45 is because there's been this increasing incidence of colon cancer, especially rectal, in people under age 50. So now a person who's born in 1990 has twice the lifetime risk of colon cancer as someone who was born in 1950, and 4 times the risk of rectal cancer. A number of the rectal cancers have onset below 50, maybe up to 15%. And when people develop it younger, they tend to show up at the doctor's office with metastatic cancer, partly because they say, hey, I'm 35. I don't need to worry about this blood that's in my stool that I've seen for the last 8 months. I must be hemorrhoids. So it's very important that those people pay attention to those symptoms. And again, the annual incidence is lower between 40 to 49, like 20 per 100,000 per year, but still very important. Is it covered by insurance? Actually, most insurance companies are now covering screening starting at age 45. Why? Because the U.S. Preventative Services Task Force sets the national guideline. So when to stop screening? I mentioned about stopping at above age 85. I think for routine average risk, no symptoms, you stop at age 85 or above. 76 to 85, you individualize. Now, would you ever stop doing it earlier? Sure. I mean, you use your common sense. If somebody comes in and they have severe medical problems, they have a cancer somewhere else that's incurable, they have really bad heart, they're on dialysis, they perhaps have a very short life expectancy, you're not going to be wailing on them, putting them through cancer screening tests. If it starts as a polyp, can I prevent the polyp? So now that would be the ideal, right? If there's something we could take, like the I'll never get a polyp pill that we could all take, that would be ideal. The only thing that we have that can make a difference is to try to be less American. In that eat a higher fiber, low-fat diet, eat enough green leafy vegetables, get enough calcium, exercise, avoid obesity, don't smoke, use alcohol in moderation. And, you know, by less American, I mean less American diet. And there's an interesting thing, aspirin. There is some data that taking a baby aspirin once a day can lower the risk of polyps ever developing. It's a real effect, but you would want to check with your doc before ever just starting aspirin, because there are downsides of taking a daily aspirin. So now let's talk about the screening methods themselves. They're divided by the experts into what are called the first tier, second tier, third tier. Third tier are not recommended, meaning barium, the old barium enema, or these serum tests, or the colon capsule. They're just not effective. Second tier is really not felt to be cost effective or practical for most people, including the Cologuard. But the first tier is felt to be both effective and cost effective and make the biggest difference in cancer incidence and mortality. And that is colonoscopy every 10 years and a FIT test, which stands for fecal immunochemical test, checking for hemoglobin or blood in the stool, doing that every year. Now, I mentioned colonoscopy is the only one-step test because all of the other tests listed, if they're abnormal, it leads to a colonoscopy. So I want to clear up confusion we often hear from other people saying, well, I'm doing the FIT test instead of a colonoscopy. It's like, well, maybe if they're every year and they're all negative and you never have any symptoms, sure. But if any of them are positive, that says you need a colonoscopy. So the top tier tests are these two. And this is an example or a diagram of the colonoscopy. So it's a flexible, steerable scope with a camera lens and a light on the end, like shown over on the left-hand side here, with an instrument channel that with you under sedation, it's threaded through the colon all the way to the end. And that's what it looks like when you're looking through the camera lens, the scope view. When you're in there, if you come across a polyp, the beauty of a colonoscopy is you're right there. You take it off. You eliminate the risk of that polyp. So you pass a catheter through the scope with a snare and you remove the polyp. So the benefits of colonoscopy is it's the most accurate test, over 90%. It's once every 10 years. Of course, if you have polyps that are found, you may be doing it more often subsequently because now it's surveillance. It's one step. It causes at least a 70% decrease in colorectal cancer incidence and mortality. And with sedation that we have now, it's essentially pain-free. The disadvantage is it's expensive. But still cost-effective in the long run because it's done so infrequently. There's the prep, the time off work on the day of the procedure, and there's some risk to it, but small. Quality, it's very operator-dependent, so you need a trained, experienced operator. Now here's an example of a colonoscopy, totally asymptomatic, routine screening, surgeon in town, friend of mine, won't mention any names, but this was in his colon, even though he had absolutely no symptoms. A very large polyp that probably would have turned into colon cancer within months. And I was able to remove it and cauterize the edges, and it was gone for good. When we rechecked it, it was fine. So saved him a lot of pain and suffering. Well, what about pain and suffering from colonoscopy? Could you induce harm from colonoscopy? It's an invasive test, so yes, you can. There is some risk, but it is very low. And here's an example of a study in Germany of academic medical centers, trained, experienced gastroenterologists, about 33,000+ colonoscopies compared with controls. They did under certain circumstances, say removing a large polyp or whatever, put a hole in the colon that would sometimes require surgery to fix, although sometimes you can repair it through the colonoscope and clip it closed. But 8 out of 10,000. There could be bleeding after you remove a polyp in about 1 in 1,000. No difference in other problems like heart attack, stroke, etc. Well, we reviewed our practice between 2005 and 2016 here in Salem, much larger number, 65,500 colonoscopies. Our rate of perforation was much better than the Germans, so take that. It was 3 per 10,000. We looked, for instance, just recently in one of our years, and it was 1 out of about 8,000 in 2018. We did have some post-polypectomy bleeds, no deaths. So yes, there are some risks, but it's quite low. So some practical points about colonoscopy. There are now multiple options for the prep that everybody dreads, famous, moaning and groaning. But an excellent prep is very important for protection. That's where colonoscopy is less than 100% protective. You might miss a polyp if the prep is poor. The sedation is much improved. We can promise people they will be totally asleep. It's operator dependent. You have to have somebody who's doing this for you who knows the proper indications when they should and should not do it, proper timing and frequency for screening, but also surveillance after polyps are found. That they complete the colon to the cecum, all the way around the colon at a high rate, over 95%. That they detect polyps at a rate expected, at least 30% in males and 20% in females or more. And our rates at our practice are much higher than that. That they do complete and safe removal of polyps. So it makes a difference. You have to take the thing off completely if you're going to make a difference. They can recognize other abnormalities and recognize and handle complications. So prepping for colonoscopy. This was given to me by a patient who actually made it for me, which makes me wonder how I actually appear to other people in public. But this is a gallon jug that has powder in the bottom. It's called New Lightly. And this is actually what I use when I get my colonoscopy. I think it works fine. I tolerate it fine. But some people have trouble with the big gallon jug. So there are other options. There's something called Miralax. There's something called the Happy Colon Prep that uses Miralax. It's a little bit lower volume. They can eat a low residual diet before the colonoscopy, the day before. So it's a little better tolerated for some people. This is Suprep. Again, smaller volume. I think a lot of people tolerate it just fine. Gives an excellent prep. But if you can't stand the flavor of that, the makers of Suprep have now brought you Sutab, which is tablet form. So you take 12 of these tablets, wash it down with a couple glasses of water, and then several hours later do another 12 tablets. So there are ways to prep that are improving. So let's go to the other test that I said is the quote-unquote top-tier test, fecal immunochemical test. This is a little test tube with this stick that you stick into the poop and put it in the tube and mail it off. And it is analyzed for, again, it's an immunochemical test, uses antibodies to detect hemoglobin in that little tiny stool sample. It's a two-step test, meaning that if it's positive, you need a colonoscopy. Now, it's mainly designed to detect cancer, meaning a cancer that's bleeding, because most polyps aren't bleeding, so you're probably not going to detect polyps. Now, it's not perfect. If you had 100 people that you knew had a cancer up in their colon and did the FIT test on all 100, 25 out of the 100 would have a negative or a normal FIT test. So, not perfect, but 75 would have an abnormal one, so it'd pick up the majority. What about polyps? It's going to miss most of them. So it's going to be normal in over 80 of the 100 polyps. So again, it's not so much an early detection test, but it is useful. It needs to be done every year to have it be effective. So there needs to be compliance. Basically, again, colonoscopy if the FIT test is positive. So why is it still one of the top two? Because I talked about some of the disadvantages of colonoscopy here. Well, number one is it's very inexpensive. It's about $10. It's easy. If done annually and you have 100% compliance, it is cost effective. It lowers the incidence and death rate of colon cancer. The second tier tests are these here. The fecal DNA test with a FIT called Cologuard. CT colonography, which is basically doing an air enema and a CAT scan after a bowel prep, and then a colonoscopy if it's positive That's not done much anymore for many obvious reasons. It's expensive, it leads to a colonoscopy quite often, and it's uncomfortable. The partial colonoscopy or flexible sigmoidoscopy every 5 to 10 years is still an acceptable test, but it's not done much anymore. So let's talk about this Cologuard. You've probably seen the TV commercials of the happy little box walking around telling you to get this test. What they don't show you is what's inside the box and how much it costs. I guess that's why it's on the TV commercial. It's about $600, $500 to $600 depending on who you ask. And that big can is where you put the entire stool, the entire bowel movement. So you have to fill that can up with your entire bowel movement. So it's a little harder than just the little fit test. But you also do a fit test. That other blue arrow is for that little test tube that you do the fit test on. Then you mail that off, and they analyze it for abnormal DNA in the stool that theoretically is being shed by polyps or cancer, and also for the trace blood. Now, it does pick up more of the cancers. Remember I said if you had 100 people with cancer, the fit test would only pick up 75. Well, the Cologuard picks up about 92 of the 100, so better, okay? But it is expensive. Studies have shown it's not cost effective. It has more false positives, but it still misses the majority of the polyps. You need a complete stool sample, and again, you need a colonoscopy if positive. So we're getting kind of near the end of the talk, and I wanted to point out this comes from the U.S. Preventative Services Task Force, and this is the type of numbers that they crunch to make their recommendations. But you see where it says COL on that graph and the bars over on the left-hand side where it says 95, 95. That's the percentage pickup rate for colonoscopies. In the purple, it's for cancer. In the green, it's for polyps, bigger polyps. And in the blue and the tan, it's still pretty good for smaller and even tiny polyps. So that's the test that's going to have the best pickup rate and the best prevention. These other tests like FIT, which is the next one over, or actually way over on the right, the Cologuard where it says FIT DNA, they're okay at picking up the cancer, but those bars are really short for picking up polyps. And this is put another way, and I'm not going to have you look through all of this, but this is kind of for your reference. But when they look at the data, what you really care about at the end of the day is, did we decrease the incidence of colon cancer, and did we decrease the mortality of it? And the champion far and away is colonoscopy, but FIT test is still good. It decreases the mortality of colon cancer substantially. They did do a cost effectiveness study in 2019, and again, they quoted colonoscopy as a 73% decrease in lifetime colorectal cancer risk, FIT every year at 50, and the Cologuard every 3 years at 46. They said the Cologuard would have to cost $8 instead of $600 to be cost effective, according to their statistics. You know, one final thing and I always point this out to people when I'm doing screening tests, is to still pay attention to symptoms and problems, because it doesn't say colonoscopy is 100% decrease in lifetime colorectal cancer risk. It's 73%. So we can't tell a person they're never, ever going to get it. But odds are very good that they won't get it if they've had colonoscopy screening. And even if it does slip through, odds are good it'll be caught early. So again, key points. We need to restart the colorectal cancer screening. There are new guidelines starting at age 45 and up to at least 75 and even up to 85 in some cases. Colonoscopy every 10 years is the best screening tool, but annual FIT is the second choice. And with that, I'll thank you. Be well. Don't get colon cancer, but if you do, catch it early. Take care.